Thanks, Chris. Thanks, Chris, for your introduction, because I'll include you into the recording so that Chris Gabor, who has done an excellent work in getting the website set up with Alistair and others. And I'm Mani Krishnan. I'm an old age psychiatrist from UK, and I've been in this delirium journey for a while. And again, like Alistair, we have seen a massive increase in energy in the last 5-6 years. We can see from the social media presence and multiple kind of a professional groups taking that lead, and it really resonates to the delirium is everybody's theme for this year. It really feels like a multi-professional kind of a fight against delirium. It's not a single professional group that's important. Everybody needs to do their bit for delirium. So I'm so looking forward to have a discussion, but also get the energy moving. And just a plug for Peter Nadal from Germany. And there's this massive flag that's being traveled around the world, delirium flag. So I think let's fly the flag for delirium, and just wish you everyone a happy World Delirium Day. Thank you. Alistair?
Hello, I'm Alistair McCulloch. I'm a geriatrician working in Edinburgh in Scotland, and I've also been involved in delirium clinical care and research for quite a while, I think since about 2004. And I've seen a lot of changes through this time. We had our first World Delirium Awareness Day in 2016, and we've seen lots of improvements in many countries across the world, in delirium care, from being a word that was barely mentioned, it hardly was present in the literature, and a few pioneers, Sharon Inouye, and even well before that, there were a few people who started this movement, and gradually it's, I think, growing exponentially now to dozens or even hundreds of researchers and people fully occupied with this. We're also seeing a vast expansion in the number of disciplines involved. Here in the meeting today, we have many disciplines involved, and also involvement of patient advocates like Mark, who've helped to remind practitioners of the importance of paying attention to the experience of delirium of patients. It's something that I think has come relatively late in the field, but I'm really delighted that we have Mark with us today. So I'm very excited. I think that this has kind of reached a turning point in the last 2 or 3 years. My feeling is that we're really beginning to see delirium as a mainstream condition that practitioners know about, and we've got a long way to go still. But I think it's really not so much the obscure condition that used to be. We used to talk about 10 or 15 years ago as being widely neglected and ignored. It's not like that in many hospitals, I'm pleased to say now, but we still have a long way to go.
Well, I can go next really briefly. So my name's Heidi Lindroth. I'm a nurse scientist and ICU nurse at Mayo Clinic in Rochester, Minnesota. My vision's a world without delirium. And so pretty much all I do, everything I think about is trying to move the needle towards that goal. I love being a part of this team. It is truly amazing to see. I mean, today is it's just the energy that comes off today, sustains me for the rest of the year. It's incredible. So thank you for allowing me to be part of it.
Hi, so as Alistair said, I am Mark. I'm a patient. I've experienced ICU delirium and perioperative delirium. So I have a kind of range of experience of what delirium is. And the main reason I'm involved in the group is when I came out of ICU, delirium was not a word that was mentioned at all about my care. And it really got to me. That the lack of the use of a clinical word for a syndrome that existed and we knew about wasn't getting used. So I became a patient advocate and a speaker to try and raise awareness as to what it is in the experiential way. So, thanks.
So I can go next. Heidi invited me. Oh, sorry.
No,
Heidi
go
invited
ahead.
me to
Go
join.
ahead,
My name's
Emily.
Emily
Sorry
Schmidt.
for interrupting.
All right, my name is Emily Schmidt. I'm an occupational therapist at Mayo Clinic, and I work primarily in the intensive care unit. Through about 7 years of dedicated ICU therapy, I've become incredibly passionate about delirium, and I think that occupational therapists can have a really big role in this interdisciplinary team as well in working on delirium.
Hi, I'm Dorothy Wade. I'm a health psychologist that works in critical care. And I was really pleased to be asked to this Zoom meeting today. I was really pleased to be asked by Mark Hudson, who, as he's just mentioned, is a patient expert and advocate for delirium. And Mark and I are currently collaborating to develop some innovative research around psychological interventions for delirious patients in intensive care. So basically, I was involved as a health psychologist, looking after patients in intensive care. And what I kept finding over and over again, the thing that was really distressing them and holding back their recovery was their experience of delirium, which tends to go along with, really frightening hallucinations and delusions, feelings of fear and terror, or low mood or anger. And we found that we couldn't really help these patients recover unless we address the experience of delirium. But we're still finding our way around the best ways to do that.
Excellent. Thank you so much for your introductions. So I guess we can get started with a bit of a discussion. Seeing as our theme for today's webinar is delirium is everybody's business, I wonder, in your own practice, in your own settings, what was the factor that you found and hopefully found to raise engagement in delirium? Was there a breakthrough moment? Was it slow and gradual? And maybe a little bit about what you can talk to what strategies you found most effective.
Yeah. So if I can go first, Chris, I think probably as a psychiatrist, as an old age psychiatrist, I started working in an acute hospital, in a general hospital, as a consultation liaison psychiatrist. It was 2015. It was the year before the first ever World Delirium Day. And what I found, it was 2013. What I found was that there was a significant lack of delirium awareness in a general hospital setting. And then we were getting psychiatric consults for challenging behavior and various things. So over the 2 years, in the initial 2 years, it was very difficult to engage in a busy hospital setting of various professionals to raise the awareness. And that's the time I started working with our nurses, our psychiatric nurses, our general nurses, occupational therapists, physiotherapists, hospital nursing care assistants, and everyone. And one of our trainee doctors, we developed a bite-sized training. And the key here is consistency and persistence of raising awareness to every professional. I've put in a little tweet today from a hospital janitor, or you want to call it a cleaning service person, a dinner lady, somebody who delivers food, hospital estate person, security, the person who wheels the patient from one ward to another ward, to a hospital manager, to a chief executive of the whole NHS hospital. Everybody needs to be aware, because sometimes things can get blocked. Small education can get blocked in a higher level or in a policy level. So over the last 6, 7 years, working through navigating. What I have found is getting that passionate people, what we are here, and gradually building a momentum has helped to increase that awareness. We can see the energy. Again, Alistair mentioned about Glasgow team. They're talking about dietitians. They have created some infographic on how dietitian can change some of our experience of delirium patients. Mobility, there was a big push on end PJ paralysis, mobilizing patients, again, let's not underestimate patient and carer experience. Sometimes a patient story really resonates well to the experience. And, Mark and there's another colleague called Lou and various people have given their own experience to be kind of educated to our group. And then we have developed various videos. So going back to, I'm just going to finish with the 3 things: awareness, knowledge, and skill. We need to be consistently raising awareness so that people think delirium is serious, delirium is life-threatening, delirium kills. As soon as people are aware of it, they will start to seek the knowledge. And then once they've got the knowledge, we can automatically develop the skills to manage and reduce the risk. So let's work together. I think what I learned is, if I, as a medic, just say I need to do delirium, I'm not going to win. A nurse alone, an occupational therapist alone, this is particularly one particular health condition. It's a golden thread that brings in surgeons, dermatologists, orthopedic surgeons, physical therapists, community matron, policymakers. It's a golden thread, but still we are grappling with improving delirium awareness. So together, I think we'll go back to Heidi's wish of there is a world without delirium. Thank you.
Thanks so much, Krish. Any other thoughts on that?
I think, Chris, can you pop the question in the chat? I didn't catch all of it, and that way people can respond to in the chat too. That'd be awesome. If you can. I know Emily and Dr. Wade had their camera, or we were ready to speak, so sorry to interrupt you both.
I completely agree with what Dr. Manny had shared. I think from a therapy, excuse me, therapy standpoint, both speaking for occupational therapy and physical therapy, our awareness of delirium grew exponentially alongside our engagement in early mobility within the ICU. I think being in that setting more, you can't help but become more aware of delirium. And so our interest and our knowledge and skills have grown exponentially from just witnessing delirium in our patients in the ICU setting more and more.
Yeah, I'll maybe chip in now. So I work clinically with hip fracture patients. I'm a geriatrician who works to provide liaison, to these wards. That's about 50% of my week. And it is very much a team approach, of course, with hip fracture care. The whole team is essential, for progress. And what we've discovered, over the years is that delirium is generally not taught very well at the undergraduate level in most, in fact, in all disciplines, even in medicine, I would say. And so people come to work without much technical knowledge of delirium, alongside knowledge that they might have of pneumonia or stroke, where people have, all healthcare professionals or support workers, all have some basic training in these kinds of things, but not in delirium. But the thing is, when you start to train people and you try to label what they're seeing every day, in the wards, this is delirium, these patients are really suffering, they might be agitated and causing challenges to your shift, but remember, this is delirium, it's a medical condition. And the people who come to work in healthcare settings are really trying to do a good job. So once they understand what delirium is, once they've had the education, then you harness all this inherent clinical skill, this inherent kindness, you know, to really make the experience of delirium care much better for the patient, and also I think makes a difference to the outcomes. You know, for example, physiotherapists, you know, I think traditionally there would be perhaps an idea that when somebody has severe cognitive impairment or delirium, they couldn't really engage, you know, that it wasn't the right time to do physiotherapy. I think now, you know, the physiotherapists I work with, you know, see you know, their interaction as an opportunity to help the person with delirium, not only in terms of their mobility, but the engagement, you know, because we've all got a lot of skills, you know, in dealing with patients. So we maybe neglect that. You know, this is what many of us have done it for many years, talking to human beings in distress and pain, you know, needing help. So harnessing that for, you know, to help people through delirium, the whole team doing it, you know, porters, support workers, any background, any work, you know, it really all makes a very big difference. And you'll see that I've just tweeted a video from Dr. S, who's a colleague of mine who had terrible delirium. And she has very generously done some interviews with me and a colleague to explain her experience. And one of the most striking experiences that she talks about was when she was still had delirium, was discharged from the intensive care unit and was extremely distressed and anxious, and that she was just being taken to a different ward by a porter. There was nobody else there, and the porter stopped the bed and leaned over, held her hand and said, "I know you're having a terrible time, but I'm just transferring you to a different ward. You're getting better, you're going to be fine." And she says that was the most important interaction in her whole hospital stay, because it explained and it helped. So I think, you know, the value of all of us knowing what delirium is and being able to communicate effectively is really very high and perhaps underappreciated. And it's thanks to my colleague and to Mark and others who've explained, you know, just treat us like human beings, you know, communicate with us, smile at us, hold our hands, tell us what's going on again and again if necessary, take care of our basic needs as human beings. You know, it's perhaps been neglected as a part of delirium care, but that's now coming to the fore.
Great. So on that note, I hope everyone can hear me. I just have some technical difficulties. I think my video stopped working. But on that note about that, you know, powerful story, Alistair, about the porter helping the patient through their experience with delirium. Maybe Dorothy, you can start us off with this one to speak to your project in the ICU. But what are the best ways to engage, you know, patients and family and prepare them, educate them, and then help them afterwards?
Yeah, thank you, Chris. Yeah, I really heard what everyone said about growing awareness of delirium, and I think I work in intensive care, so my perspective is mainly about intensive care. So I think in the intensive care world, I think there have been breakthrough papers and breakthrough research, but I think sometimes still in the intensive care, practical day-to-day clinical world, delirium is just really regarded almost as an occupational hazard. And we think, oh, well, they're in critical care, of course they've got delirium. So I think it's quite important to keep trying to help raise awareness of the actual, as I said earlier, the sort of emotional and psychological impact on patients of having delirium. And I was also struck, as Alistair said, that critical care staff haven't really had very much specific training in delirium. And I think particularly because ICU delirium does seem to often be quite extreme in its sort of manifestation. So you do have a lot of patients getting so frightened that, you know, they start wanting to pull their breathing tubes out and jump out of bed and getting very, very angry. And ICU staff have had no specific training on the whole on how to actually manage that situation and how to help the patients. And I think quite often it can be the healthcare assistants who are kind of given the job of minding a delirious patient all day. And again, I think that must be a very, very difficult thing to do when you've had no training in really how to do that. So I've had quite a lot of focus on, in research terms, trying to develop some sort of training modules on specific communication skills that you can use, not just with all patients, but specifically with patients who are extremely distressed or delirious. And we can sort of, in the intensive care world, we can borrow a lot, say, from the care in geriatric medicine, I think, which is tries to be extremely patient-centered and thinking about, behind agitation, or what we call agitation, there's often unmet needs. So trying to find out, what are the unmet needs? It can be something very, very simple that we could just, if we were able, which the patient, is unable to communicate to us at the moment. But it could be pain, hunger, or thirst. Sometimes you find patients are very, very distressed that they can't get out of bed and go to the toilet, and they can't understand this situation, but this is really, really worrying them. That can become, a massive worry to them. Or they can't see their family around, so they're just really worried about where is their family okay? Sometimes even they've just woken up and they start thinking about who's paying the bills, who's paying the rent, and they can get very worried about that. But if they can't communicate that, then they can be becoming more and more distressed. So I think another sort of clinical world we can learn quite a lot for is communicating with patients who have psychosis, because some of our patients are a bit similar in that they might be having really frightening hallucinations and delusions. And colleagues, mental health nurses who work in psychosis are really, really good at knowing how to talk to patients in a way that doesn't distress them further, talking in a really sort of calm, gentle voice, never raising your voice. I don't mean even in an angry way, but quite often as healthcare staff, we do talk quite loud to get patients' attention. And sometimes that can just alarm them more. Giving them a lot of personal space, trying not to move in a fast way, slowing down your movements. Giving them, because when you're delirious, you are, at that moment cognitively impaired. So giving them time and space to think about what they want to say and tell you about it. And as we know, never arguing with patients' hallucinations or delusions, or laughing at them or making fun of them or minimizing them. But while also not confirming their delusions or what they think is happening. So it's quite a tricky balancing act. But just telling them that our main focus is helping them to keep safe and calm, connected to their loved ones. So I think there's a whole range of things like that, it would be great if we could bring that together and make sure that everyone has that basic training in just knowing how to sort of calm and communicate with patients with delirium.
I think you have summarized it excellently, Dorothy. I think what sometimes again, as a psychiatrist, I can completely, draw some of our experiences. Rather than pigeonholing something into a diagnosis, there is somebody in distress, as you rightly said. When it comes to delirium distress, the patient is distressed, the staff are distressed, the family are distressed. It looks like this distress is a continuum. And then rather than, it's almost like stepping back and saying, going for a treatment bit, how can we reduce distress for all of us? I vividly remember there was a patient, 90-plus-year-old patient, was so distressed, and she was trying to stab somebody with a little butter knife. And then I was called to section this patient to take away into a psychiatric hospital. And then everybody, they were like, there's a big audience, 10 people surrounding this little old lady in a hospital ward. And then everybody was completely distressed. The only thing what we needed to do was like what the police will do, move everyone, calm everyone down. And then what she wanted was just a bottle of Coke. That's all she wanted. She wanted a drink of Coke because she didn't like the hospital squash. And that was the only reason, as you said, that's her distress. She said, I want Coke. They said they don't have Coke. They gave her this, yucky hospital squash. So going back to, it's the distress bit and how we communicate when somebody is in distress, and everybody can communicate. There are some people who communicate better than highly skilled professionals sometimes. So use the people who can communicate is a really important thing. Thanks, Dorothy.
Mark, go ahead.
Yeah, so I just wanted to cover a few things. I think some of the best strategies for get people to engage in delirium care is to get the patient to speak to them, because I've found that when I tell my story, people are far more willing to buy into the idea of delirium and that it needs to be treated and managed, because I think in general, everyone that's in healthcare is wanting to help people. And when they find out that this system, particularly in ICU, where it's a work hazard, that they kind of want to tackle the problem. So I think that it's a thing that's very underused. You won't necessarily, every person that has experienced delirium doesn't want to talk about it. In fact, quite a lot of people don't want to talk about it. But if you can find patients who are willing to talk about it, then they are a very powerful resource for change that you can sort of use and focus. In terms of a lot of what Dorothy said was, I think particularly in ICU, it's an environment that is so delirium causing, between the sedation, the isolation from familiar situations. Family might be restricted visiting, particularly during COVID. There's lots of new people, stimulus of noises and things like that. And I think a lot of this can't be managed away, but things like how you speak to the patient is extremely important. And that the one nurse that I had a positive view of during my delirium was a nurse who spoke to me constantly about what they were doing, why they were doing it, where it was, and was very protective of me from other things going on. And I think that that's really important, in that of this experience where everyone was trying to kill me, everyone was trying to hunt me down, everybody was trying to torture me. There was only one person who wasn't in that mold, and this is what he did that seemed to have that effect. And even after I came round and was aware that I had delirium, I didn't know what it was at the time, my distrust of the staff was still there. I still didn't trust the vast majority of the staff because I didn't know these people. And as far as I was concerned, 2 days ago, they were torturing me. So I think it's more important than you think to speak to a person that's delirious as a human being and trying to use the soft tones, be reassuring. I would strongly advise against engaging with delusions, and when I say that, I don't mean like telling them that it's not, but I also don't mean going along with it. I don't think that these are positive things. I think that they can cause a problem of trust between you, in that you've broken that trust by either dismissing them or pretending to go along with them. So I think those are very important things, and I think sometimes they're not thought about much.
Thank you, Mark. Anyone else have anything to add to that?
Yeah, I mean, I remember there's a few stories. I mean, I've told you about the portable one. There's another one which actually really is quite close to what Mark was saying in terms of there being an individual who made a difference. And Rachel White, I think her name was, who spoke in 2009 at the third European Delirium Association meeting, 20 minutes about her experience, said that, you know, she had, you know, a lady in her 50s who was previously quite well, you know, just had sepsis and ended up in intensive care and had awful delirium, where she was in fear for her life for a lot of the time. And she's, for example, she's thought she'd overheard the nurses at the door of her room saying that she was given a CTO, which is what she thought was a compulsory termination order, which meant she was going to be killed because she was too sick to survive. So when they moved the bed into a different room, she was fighting for her life because she thought, I'm too young to die, you know, I haven't said goodbye to my family, things like that. But then somebody in the audience asked her after her talk, you know, was there any moments where you felt better? And she said, yes, there was one day where this nurse, who was, you know, very kind, you know, held her hand and told her, I know you're really frightened and you're having a terrible time, but I'm here for you today. I'm going to be with you all day. I'll be looking after you. It's going to be all right. And she said that day she didn't feel fear, just because of, you know, that conversation and that specific recognition of distress, recognition of this person's fear, and you know, the value of the direct communication with that person. So that's something we can all do every day when we're looking after people with delirium, and also people who are vulnerable to delirium, who might get it, you know, who're scared before surgery or when they're unwell, you know, just keep giving them a framework, telling them who you are, what you're doing, explaining what's going on again and again if necessary, especially if they have dementia, you know, that they're not alone. I mean, my colleague that I've posted the video for, you know, she said that, you know, I'm going to be posting various snippets as the day goes on, but, you know, that shame was a big part of what she felt. Shame and, you know, isolation, you know, she felt completely alone. You know, she didn't have a friend in the world, and it was just darkness all around her. And whenever people cut through that, she talked about hands reaching through the darkness, a very powerful image. You know, it made her feel much better, you know, every time somebody made the effort to do that. So we can do that all, you know, every time we're interacting with patients. Even it won't even cost any time sometimes. Sometimes it might, but sometimes it will just involve while you're doing something else. You know, you can just chat to them, and you know, it's amazing how powerful this is and how little it's done. And it's all about education, isn't it? And you know, sharing people's stories like Mark's and my colleagues, and just making sure that many people, as many people as possible working in healthcare with people with delirium, hear about this and then integrate it into their day-to-day work.
I'm curious, and you know, anybody from the audience as well, if they have a story, does anyone else have sort of a similar story where a patient was, you know, experiencing delirium, and it was just a very simple intervention, whether it was you know, providing hearing aids, a drink of water, or just that reassurance that made the difference for them? Is there anyone else who can has found that, has experienced that?
Yeah, unmute yourself and join in. Yeah. Hi, Jim.
Hi, everyone. Thanks so much.
Welcome.
Happy World Delirium Awareness Day. I want to share a story, but it's about what a resident and I did. And we sat down one day and we calculated how many unique people enter a person's hospital room on a given day. And I guess we could do it in the chat. You know, guess how many people in the US enter a person's hospital room on a given day? Unique. North of 8, Manny. Yeah, Emily's closest right now. So we counted 32 unique people enter a person's hospital room on a given day. And if you imagine that those people show up and often deliver the food tray and walk out, or clean the bathroom and walk out, or, you know, fix the IV or do vital signs and then walk out without ever introducing themselves, you know, put yourself in the hospitalized person's room. They have limited hearing, limited eyesight. It smells rather sterile. We're feeding them food that tastes like paste. All of a sudden, they have no interaction with that outside world. And to engage with someone, even if it's just, hi, I hope you really enjoy your meal here at the hospital. That is a huge orientation stimulus and a huge opportunity for us to improve the cognitive function of these people just by being human.
This is mind-blowing, Jim. I think that's the thing you can see clearly when 32 different, imagine if you are in your own personal household and there are going to be 32 people knocking your door in and out. Even if you don't have a delirium, you are going to get delirious. You know, even at 6 o'clock, if somebody knocks in about selling window glazing or something, we get irritated, we get annoyed. In our private home, this is their private room in a hospital. That's a very powerful. I need to pinch that one and then get a little infographic out of it.
And even think many of them don't knock or ask permission to enter the room. It's strangers entering your home.
Yeah.
I think one of the scariest things is when large medical teams turn up en masse. I think that's probably one of the main offenders. 13 or 14 people, and then they crowd around the computer and talk about you. And
or they circle the foot of the bed, right?
Mm.
They circle the foot of the bed looking down on you.
Yeah,
and
I think
I've had other patients say to me that one of their favorite people was the cleaner that came in every day, because the cleaner would come and then they would always chat to that cleaner. The cleaner would be like a normal person that just talked to them as a normal human being rather than talking about them in obscure language. Yeah. I think
and
also
then again, Heidi mentions not only people entering, we almost talk them as a third person when they are live in front of you. And then they say, he must be having this, he has got this, she has got that. And then they think, who am I?
I think a biggest pet peeve that I see is expecting that a patient's not going to talk when they are at full capability of verbalizing, and multiple teams letting that just be normal. I often tell my patients, we want you to communicate. We want to hear what you have to say. We want to know what you're thinking. So please share that. And I think that invitation is important, because so many people just assume, they're not offering anything. That's fine. And that's
Absolutely,
not normal.
Emily. And also stereotyping, isn't it? Like, about 2 weeks ago, my daughter, who's a medical student, told me one of her senior residents told her, I wouldn't go and talk to that particular patient. That patient is very delirious. Don't talk to her. And then obviously she's a daughter of somebody who does delirium for business. So she went to this lady. She had no teeth. She had no hearing aid, and she had no glasses. That's all she needed to get. And that lady had no delirium whatsoever. She's a retired mathematics professor, very unhappy in the hospital, quite frail, very unwell, but zero delirium, extremely intellectual lady, but being stereotyped, don't go near her, she's got delirium. So there is still a lot of myths about delirium. And again, we talked about training. From a first year medical student, first year nursing student, any student, everybody, it's almost like a vital sign, as Jim always put. We teach them how to check pulse, we teach them how to check blood pressure, but we do need to teach them how to look at a confused person.
Yeah, so I just wanted to come back in about staff coming in and out of your room without knocking. That is one of the things that annoys me the most. just in entire healthcare, of all the things that have happened to me and done to me, it's the thing that really affects me the most. In that, if we're talking about just in delirium setting, if you're trying to make a patient feel safe in your care, because we all know that if they don't feel safe, then delirium's a big hurdle to try and address. If they have no privacy and no security, how do we expect to have a person feel safe when they don't know when the next person could come in, when that person comes in at 3 o'clock in the morning when they're trying to sleep, when there's quite often not a communication between that person and the patient about, at least in the initial stages, who they are and why they're there. This creates an environment of almost antagonism, in that you are invading my space and then not respecting that that is my space. It's a thing I've discussed quite a lot. That hospital room might be your workplace, but it's my home while I'm there. And you wouldn't just walk into someone's home and expect them to be happy about it. And I think it's a bad habit that that seems to have developed in healthcare. I think some change has been made. I think it's not nearly as bad as when I was much younger, but it's still bad. And I still think that there is that disconnect between the workplace mentality and the home mentality of the patient and the healthcare staff, and it's not helpful for delirium, particularly in ICU, because if you're not sleeping, I think if I remember correctly, it's about 2.5 hours you're sleeping a night with 1 minute sleep times. So that just heightens all of the bad things, all of the sort of tensions and anxieties that exist while you're in ICU, constantly feeling unsafe, which is probably why ICU delirium is usually quite horrifying when people hear about it. Yeah, so I think, although it's not directly tied to delirium, I do think it has a negative impact, and it's just bad practice, just in general. That if we could get rid of it, that would be quite good.
Thanks.
I think an important thing to acknowledge is, oops, sorry.
Go on, Emily.
Okay. Patient dignity and decency and appearance, as well as how it plays into delirium and how a patient is perceived by others, other healthcare professionals and providers. I think, another colleague shared the example with me that there was a patient that was delirious and at one point had not wanted to wear a gown and was laying naked in their bed for days on end without anyone addressing that and letting that become their norm because of one instance that had happened. That is not treating our patients with dignity and respect that they deserve. And then I think just as an occupational therapist and as well for nurses, never underestimating just the value or impact that helping someone wash their face or brush their teeth or comb their hair can have on their day-to-day, kind of coupled with how we speak to our patients with kindness. Let's also treat them how we would want to be treated in terms of our appearance as well, and what impact that can have.
That's really important. Just another plea to audience, join in if you can. Yeah, go on, Dorothy.
Yeah, it'd be good to hear from the audience. But I was just going to say another factor we haven't really talked about too much is the role of family. And that's something that quite worries me at the moment, because pre-pandemic, when a lot of us had started to have very liberal visiting hours in ICU, which I thought was a very good thing, I often found that sometimes you could get patients through a very, very difficult experience with delirium, if sometimes their family, a very trusted family member could stay with them even all night, and that would mean that person would get through the night without having to be injected with haloperidol or anything else like that, but just knowing that safe person was there. Then of course during the pandemic the families were all kept out, and we really noticed delirium becoming in ICU becoming a lot worse and more acute and scary for the patients, and they felt very isolated. And now I think there's just a slow return of families, but I think a lot of places seem to have taken the opportunity to really restrict visiting hours. And I feel like if you asked now, could on this occasion we just have this family member stay the night, that would be a very definite no. But I think family, as just to say that they're really one of the greatest allies in fighting delirium, but they can't always be around and as helpful as they used to be, or I'm sure they want to be.
Yes, and I think we need to sort of go to the post-COVID era now, even though it's still around, it's the mentality has to go back to what it was before, because even if it is still around because of widespread vaccination and so on, it's not the threat it probably was at the very beginning of the pandemic. And I think it needs to balance. I think we've also realized about the competing drawbacks, of being so restrictive, with COVID, although I think at the very beginning, when it was unknown, it might have been reasonable. But I think, as it dragged on, I think we realized that maybe some of the measures that were taken were over restrictive, and we mustn't that hangover mustn't persist, I think. But one thing I wanted to point out and maybe ask other people's view is we do often talk about the role of families, but my colleague, Dr. S, she said that her family were never told what delirium was. And even though they were there, they were equally bewildered, and the staff hardly spoke to them either. And it actually wasn't all that helpful to have the family there, because she could see they were distressed. She was unable to articulate how she felt, because it said her inattention was so bad, her brain wasn't working properly. She couldn't speak. She wasn't intubated at the time necessarily, but she just couldn't get words, sentences out. And it actually distressed her because the family was distressed as well. And she said, if only somebody just given them a leaflet and said, your loved one has delirium, and this is what delirium is, and this is how to support your loved one through this. So I think that's a massive deficiency as well. Like, I mean, I've been guilty of it as well. Say involve the family, but we absolutely need to tell the family what delirium is, and give them even just some simple bullet points as to what can help. And also they will be distressed themselves, watching this happen, and often in great fear as to what the outcome is going to be. So that's another massive area which I think we could be doing so much better in. And hopefully in 5 years' time, in World Awareness Day 2028, we won't be speaking in the same terms about this complete barren landscape of information for families and patients.
Right,
Absolutely.
we talk about that patients.
Yep. After you, Emily.
We talk about that patients can be embarrassed or ashamed of what happened at that time, but the same thing can be happening for loved ones, saying, this is not my loved one. I can't believe they're acting this way, or they're aggressive. They would never be this way. I think that sense of shame and embarrassment is equally present in family members often. And I think it's a low-hanging fruit to make just a very bullet point education to family part of our routine practice. And I think even before delirium shows up, why not tell the family members that that's something that could happen? They're often the best at watching for that change.
Yeah, absolutely. I think, again, Alistair, as you rightly said, sometimes professionals do themselves, are not very well aware, because it is going back to the distress situation. There are many times my own colleagues whose loved ones have got to delirium, and then when the ward just says, by the way, I think your father might have delirium, and then move on without even sitting them down and explaining. I get like messages saying that I think you do something about it. Can you send me that video again? Or like, that little bite-sized information. Even somebody, if we think about heart attack, stroke, people actually will explain, and also go back to the Dr. Google thing. Even if we say, here is some information, Google them, it'll give you that basic information. Signposting family really can change their understanding. It'll at least reduce the distress, and then they carry on sharing to everyone. And we do think that it is everybody's business, but not just about preventing in the medical management of it. Talking to the family, we talk about leaflet constantly. We still find, if you do an audit in any given time, patient leaflet, patient information, patient discussion, very low when it comes to delirium. That's what I find.
I do want to open it up to the audience if anybody has a comment around engaging families, or a separate question just in our last few minutes, so everybody gets a chance.
This too is a separate gift, right? And this would be one box.
Anybody has a question they want to ask?
I think Larissa mentioned in Brazil, they do psychoeducation to reduce the family distress.
Okay, there's no other questions. Then the last question I had really was, what do you think?
Oh my God, I'm so obsessed with that. Like, even if I buy for my friends, I get this.
I think somebody is not muted.
Yeah, the woody musky ear, it's really nice.
iPhone, you can mute iPhone.
Yeah. Go on, Chris.
Yeah, sorry. I just the last few minutes. I was just wondering from anybody can take this. What do you think is the next priority? The next, if there was one change you'd like to see,
you can take it out, please. Yeah, it'd be nice if it's out.
What would that be? What would be?
Whoever is iPhone, you are not on mute, and then we can hear your personal conversation. Okay, thank you. Go on, Chris.
So yeah, I was just hoping to get an opinion for what if in terms of next steps, what would be the biggest change, or what would you like to see that would make the biggest impact for delirium care, delirium prevention?
Yeah. I think again, I suppose the key here is the very fact that we have got a multidisciplinary participation, patients, allied health professionals, occupational therapists, physiotherapists, physical therapists, psychologists, physicians, geriatricians, psychiatrists, nurse educators, researchers. That itself is already a win. What we need is every individual professional, like you said, what they have to do in their professional kind of a remit that's made a change. And then we probably get these stories. I think we do need more stories. I think we are giving a lot of anecdotal thing, but bringing people together, and also, almost like having that goal of each one, how we are eliminating or reducing the risk, will be something we should think about next year. And the other thing is whether we make it even more interactive. I think we're still around between 20 to 30 people. What would be helpful for more engagement and this kind of a chat? I think because it's been really useful. So that could be a useful thing to think about, whether do we need to do in multiple time zones? Do we do something? And again, it's great energy. I think Heidi will tell us towards the end of this week about the Twitter kind of a statistics, but I can see definitely, I'm sure Alistair will agree, from 2016 to now 2023, I would probably say, even barring the COVID 2 years, the amount of proportion of increase in the energy in delirium prevention and delirium awareness. Probably I would say at least over 100%. I don't know, Alistair might say, yeah.
Yeah, I totally agree. I mean, I'm overwhelmed by, I can't keep up with the Twitter, hashtag WDAD 2023, and anyone listening, please keep retweeting and let's get our impressions and, the reach of this up further. But it's faster and bigger than I've ever seen before, and it's only, I mean, North America is waking up now, and, there's a big delirium contingent in North America, lots in Latin America as well. So that side of the world is going to, is going to be making a massive impact in the next few hours. And obviously a lot of UK, European, based people are going to be at work at the moment and maybe less time, but in the evenings, I think a lot of people will be contributing as well. So we've already had a very strong start from the Oceania, kind of Australasia kind of area of the world as well, which is so it's going really well, and I think it can only get bigger. We created our new website, deliriumday.com, about just 4 weeks ago or something, and it's still relatively small as a website. I mean, I think the content on it is very good, but I think by the time of next year, that'll be a permanent fixture, that website, and we'll have collected much more by next year and a lot more resources, and probably another educational website will exist by then. So I'm optimistic, but I think the more people can be, I've just seen in the chat some amazing infographics. We can hopefully download and harvest those and stick them on our website, as well as a collection of infographics, because people can print those out and have them as posters in their wards and things. So the more this is democratized and spread down, the world, so that even people who are not necessarily involved in delirium research or as recognized teachers in it, it doesn't matter. Anyone can say, I love being good at delirium. I feel I can make a contribution, and I'm going to be the person that teaches and facilitates good delirium care in my ward or in my hospital. Just do it. I mean, that's why all of us have only ever done it. At one point, we realized that we liked to care for delirium and we're interested in it, and we've just kept going for a few more years than some other people. But everyone's invited, to take part in this important movement for improved delirium care.
Yeah, just to point out, everything is free. Every resource is free. Again, that's the beauty of how we have grown organically so much that every infographic, whatever we have produced, the logo, the background, everything is free. So we just need to carry on spreading the word. Anything else, Chris? Or I think we're we've been doing for an hour, Heidi.
Yeah. So Chris got dropped off and he can't get back on. So he
Okay.
WhatsApp chatted me to close and say thank you to everyone for joining. It's been an amazing conversation. We recorded this. We'll put it on our YouTube channel. And just thank you so much for all of your work and this team. It's incredible.
Thank you so much, and thanks for those tuning in. But explain to your colleagues that it will be on the iDelirium YouTube channel, so Delirium Day YouTube channel, so you can signpost to your colleagues and friends, everyone. So a whole new topic next time. That's really good, Dorothy, definitely. So thank you so much. Thanks. Have a good day and happy Delirium Day again.
Thanks, everyone.
Thank
Take
you,
care.
everyone.
Thank you. Bye-bye.
Bye.
Bye.